the important thing, two things actually. One is money, and the second is life.
When people go for medical checkup, they have this perception is that when they have done the medical checkup and everything seems normal, means they are actually cancer-free. But in actual fact, it's not the case.
Making the patient journey smoother, also looking, of course, to expand the projects with more pharmaceutical companies to help more patients and maximize the patient benefit.
Do your screening and know your status, and please get yourself get your proper treatment.
What would be your wish for cancer patients? Hello, good day everyone. My name is Neni Ileana, Managing Director and Founder of Bridges MNC. We are a medical and healthcare communications agency, and we are here together for a webinar entitled Addressing Healthcare Access Barriers for Cancer Patients. We have a full panel with us today. So I'd like to introduce the panelists, and the first would be Dr. Nur Ariana binti Hassan. She is the Deputy Director, Non-Communicable Diseases from the Disease Control Division, Ministry of Health, Malaysia.
Hi everyone.
And next up, we have Dr. Muralitharan Munisamy. He's the Managing Director of National Cancer Society of Malaysia.
Hello.
And we also have in the studio with me, Dr. Tan Chi Kiang, Consultant Clinical Oncologist from the Picasso Hospital, Kota Damansara in Kuala Lumpur, Malaysia.
Hi, everyone.
And last, but certainly not least, we have Ms. Shahad Safa Adnan, Global Head, Access to Treatment, Axios International, joining us all the way from Dubai.
Hello, hi everyone.
All right, let's begin. So we have 4 parts to this webinar. The first part would be on the cancer landscape in Malaysia, and that would include diagnosis all the way to treatments. And that would be followed by barriers to accessing innovative therapeutics. Thirdly, the importance of early diagnosis of bridging the affordability gap. And finally, looking ahead, where multi-stakeholder collaboration will be examined and looked into. So first and foremost, this is a question for the Ministry of Health official, Dr. Ariana. So we're looking at the cancer landscape in Malaysia. We're looking at the prevalence of cancer in Malaysia. What are the main cancers in terms of the highest incidence rates? And also the development of drugs, because if you look at 10 years ago, or even longer before then, people are living longer, but more drugs are also being invented to treat more cancers.
Thank you so much for inviting me today to this discussion. And if you can see from what we have right now, the landscape of the cancer burden in Malaysia is actually increasing. For your information, we have what we call a National Cancer Registry. So every patient who diagnosed to have a cancer to be notified to this cancer registry program. But unfortunately, one of our challenges in this National Cancer Registry program, it is a voluntarily. It is not mandated. It's not what I can say. It's not something legally in the act that you must notify. So in that process, in the registry, although it is only voluntarily, we managed to collect the information, and we managed to have some statistic and to see our landscape of cancer in Malaysia. And what the data that we have, the latest data that we have is the cancer cases reported from 2017 to 2021. That was the latest that we have right now. And we compared to the previous report that was in 2012 to 2016. So in 2017 to 2021, a total of 168,000 cancers were reported in Malaysia, and it shows an increase to 46.5%. It's actually quite a lot if you compare to the previous report that we have right now. And if we talk about the most common cancer in Malaysia, the highest one is still the breast cancer. The incidence rate is around 17.6 per 100,000 population, and followed by colorectal, and lung cancer is still the top 3 of the cancer in landscape of cancer in Malaysia, and followed by lymphoma, liver, prostate, leukemia, nasopharynx, uterus, and ovary. But the thing that I would like to highlight here, the lung cancer is still the highest, one of the top 10 among male in Malaysia, and also among female. So for male, lung cancer, colorectal will be still the top one. Second will be the lung cancer. And for female, breast cancer is still the most prevalent one, and followed by colorectal and lung cancer. In our previous report, the latest report, I would like to draw the attentions of all of you here today that maybe, so this is another important thing that we should be discussing in the latest, what we can say in terms of the liver cancer. Because previous report, we don't report liver cancer as one of the cancer, but our new landscape, it shows that liver cancer already be in the top 10. It's actually in our number 5 out of the top 10 cancer. So this is something very important for us to have a discussion, for us to look into how we can discuss in terms of the screening, in terms of the treatment, and so on and so forth.
So the rising incidence of cancer, has, brought us to the rate of which it is being diagnosed. And obviously, many cancers are being diagnosed late. So this is a question for Dr. Murali with regards to the factors contributing to the high prevalence of advanced stage cancer diagnosis. So what are the common issues that could contribute to that?
Okay, let's look at it from systemic perspective, and then we look at it from an individual perspective. Yeah, from a systemic perspective, I think as a health system, we still face some challenges in screening people and diagnosing people early. In the sense that we have a very good public health system, but unfortunately it's very overloaded. So people take a long time to work themselves through the system, and that causes a bit of delay, a significant delay actually, in getting people to be diagnosed on time. On the other hand, we have excellent private healthcare facilities, but the challenge is accessing them, in the sense that people don't have insurance, one. Second, most health insurance, especially those in like say for people who are in their 40s today, the insurance plans that they signed up to 20 years ago doesn't really cover things like screening or diagnosis. So these are things that are not covered. So people have to pay out of pocket. That's a challenge for them to get to private healthcare as well. So these are kind of big systemic challenges. And of course, Malaysia is kind of geographically a little bit biased as well. On the west coast, especially in some of the bigger cities, you have a huge abundance of private and government and even university hospitals. And then in some areas, there's just crick. There's almost nothing. So that is a challenge, especially for some of our Malaysians who live on the island of Borneo. So that's a challenge. So in terms of individualities, there is, and though people like me, Dr. Tan, Dr. Ariana, we've spent, I think, quite a significant amount of our lives trying to convince people otherwise, there's still this huge fear, stigma around cancer, where people are reluctant to go for screening. And when they do go for screening, and because screening is not an endpoint by itself, you pick up something abnormal, you want to go on to get a diagnosis, people sit on it for a significant amount of time. Again, it's a bit of a mix between fear, confusion, and then Dr. Google, what is this, Professor WhatsApp, and everything else that you get around it as well. And now the latest, I think, consultant, Professor Dr. TikTok, who has joined the fray as well. So people watch a lot of misinformation, and that causes delays as well. So there's an individual kind of pocket, and there's a systemic kind of pocket that leads to this.
So let's talk to Dr. Tan a little bit about the impact of delayed diagnosis on patients' treatment and the real reasons. I think Dr. Murali spoke about the real reasons why patients delay treatment or delay diagnosis. You know, as a medical oncologist, what has been your clinical experience?
I think like what Dr. Murali did mention earlier, I think systemic problem, that's one. I think a lot of times when we see the patients coming in, walking through the clinics, having late diagnosis, right? Sometimes it's about the knowledge that they have or education level in terms of like what they do. It's very common for us to actually see patient who comes in, like say with advanced stage diagnosis, and then they will just tell you like, why, doctor, why am I still having the stage 4 cancers when I just had my medical checkup, probably 6 months ago, or 9 months ago. I think first issues here is that I think when people go for medical checkup, they have this perception is that when they have done the medical checkup and everything seems normal, means they are actually cancer-free. But in actual fact, it's not the case. I don't think there is any specific medical checkup package right now at the moment available in any of the private hospitals which are able to tell you that you are cancer-free. In fact, most of this medical checkup was made for cardiovascular diseases rather than for cancer diagnosis, because I think, as you all know, cardiovascular disease is one of the top killer, in terms of medical reasons, right? So hence, I think if you look at most of the medical checkup, they have like, your blood pressure, diabetes, cholesterol, ECG, stress test. All these are mainly tailored to look for heart problem rather than cancers. And a lot of times you can see that, they will then bundle up with the tumor markers, which is just from the blood test, causing you, let's say, maybe 200 ringgit extra for a few tumor markers. And when the markers came back as normal, then you have the perception that, oh, I'm actually cancer-free. But it's actually very wrong in that, because number one, tumor markers are not sensitive or specific enough for all cancers. What it means here is that someone might have a cancer, but the markers can be completely normal, right? Second point is that not all cancers has tumor markers. Like what Dr. Ariana mentioned earlier, like for example, liver cancers, right? You don't really have a marker for liver cancer per se. And third thing is that sometimes this marker is not sensitive or specific enough, meaning that the markers can be slightly abnormal, but patients actually do not have that cancer. So hence, issue with that. So actually, the patients actually need to specifically look for a screening test if they want to rule out certain cancers. I think that's one of the main reasons why a lot of patients coming in with late. Of course, the other reasons, like individual reasons that we mentioned earlier, is that a lot of time is mainly due to personal reasons as well. At the same time, there are people who are afraid that they might be a burden to their children once they are diagnosed with cancers. There are also patients who felt like once they are diagnosed with the cancer, for example, breast cancer, then when they have to do surgery to remove it, then that might lose their families and all these things as well. So there are a lot of reasons. I mean, like if let's say patient were to present in earlier stage of the diagnosis, I think there's a huge difference there, because the treatment is mainly curative intent, right, as well as the shorter duration, and this is also significantly lower the cost of the treatment, as opposed to someone coming in with later stage, like stage 4 of the diagnosis, when they are diagnosed with a cancer, then generally the treatment is going to be lifelong till the patient pass away, and of course it also comes with a much more higher cost, and finally the treatment is mainly just to control the disease rather than to cure the patients.
All right, this is a question for Dr. Murali. So, in your experience working with the National Cancer Society of Malaysia, so how do patients tend to pay for treatment in general in Malaysia?
So this is the really bad statistic. It's a sad fact that only 22% of Malaysians have health insurance. So that ends this conversation. The 80% struggle through various means. So some people have limited employer insurance coverage, which means I'll pay you for cough and cold, one big diagnosis, you fall off a tree, I'll pay for some minor surgery. But the moment it goes into like a cancer diagnosis, that's the end for these guys as well. They don't get covered. Now, the government, if you're working in the government sector, public sector, they're a little bit kinder. They don't pay for treatment, but generally you have access to the public healthcare system, and generally as a civil servant, you have slightly better perks. Treatment standard is about the same, but then you get a bit faster in the queue, that kind of thing. But otherwise, almost everybody else has to pay out of pocket. And the problem with paying out of pocket is, as is with the most of us, when you have 10 ringgit, you then choose whether to have a Ramly burger or a 7-Up. And unfortunately, cancer, like most other diseases, treatment is not something you can pick and choose based on, okay, I got 5 ringgit, so I'll do radiotherapy for 1 week. So it doesn't work that way. And unfortunately, people are being forced to work that way because that's what they have in their pocket, especially if they're not within, they don't have a system where they can access drugs.
Right, this is a question for Ms. Shahad from Axios International. So working in Malaysia and Asia, obviously you've been exposed to gaps in healthcare access, and cost is just one of them. So from your personal experience and working with Axios, how has that been evolving? You know, how have you, as part of Axios International, see trends within this space?
Okay, so first of all, we need to understand that, and just like Dr. Morley was saying, and even Dr. Noria, when they were mentioning about the reimbursement challenge, and especially that the patients and the high percentage of patients are not being able to have a good coverage and to give them good access to their healthcare. Here, Axios come where Axios International is a healthcare consultant company where it was established since 1997, and their main core of business is to design and implement innovative access strategies. When it came to Malaysia and when we noticed all these challenges that comes with the patient, so we had to go on the ground and come up with solutions, especially with the involvement of the R&Ds and the innovative medication that being very expensive, and even it's being allowed on even on the government being asking always for the alternating funding and to be able to sustain the patient. Through our offering of, we say, the patient access programs and the cost sharing model concept that brings together more than one stakeholder, which is including the pharma companies, including the insurance, including for sure, the core business with charities and NGOs, and of course with the regulators and all other stakeholders like HCP, distributor, and pharmacy, to ensure a sustainable treatment plans for the patients whenever they are diagnosed and they are prescribed with one of the chronically ill medications and they are very expensive. We are being there to be able to help them in offering them a sustainable treatment plan to ensure they continue, and from a clinical point of view and of course following the HCP point of view, to ensure that whenever the patient is starting, they are able to continue and not to burden the other parties. So bringing all together one or more than one party, it was a solution rather than just relying on the regulator on reimbursement or going back only to the charity to cover. Bringing all these parties together was the solution to help ensure the patients being able to access their treatments.
You know, in spite of the investments, people don't realize, or they might not know, that only 16 to 19% of all the products that enter clinical trials eventually make it to market. So for pharmaceutical companies, those who are innovating to create medicines for treatments, you know, they will have to somehow maintain or sustain innovation in some way. Somebody has to pay the bill. So if it's not pharma companies, then it has to be, you know, the patient. If not patient, it's government. But the buck is being passed from, you know, party to party. And I think this is why, you know, collaboration, multi-stakeholder collaboration is really, really essential. You know, we bring together NGOs like the NCSM, the government, you know, and healthcare practitioners, as well as healthcare access companies such as Axios, to help narrow these gaps further. So speaking about now the barriers to accessing, yes?
And if you allow me just to add a point here, and really Axios is there because we are following the patient-centric approach. We don't want the patient to pay the bill. Patients with their affordability criteria, they need to be served properly in order to be helping them during this journey. There is one of the hematologists who was mentioning that already the patient is going through 2 shocks. The first shock is that you have a chronic disease and you have a cancer. Then the second shock, that there is a medication, but it's very expensive. So these 2 shocks to the patient, we should not be there to make them pay the bills. That's why Axios is there to collaborate all these efforts, just like you mentioned, and ensure the multi-stakeholder involvement to provide them with a smooth journey throughout their disease.
We will get to that part in a little bit, but let's talk about the barriers. I think we've addressed the barriers in the first part of the webinar. And we're looking at MOH, the Ministry of Health, the availability of treatments from standard first-line treatments through to innovative treatments. From my understanding and study of the Malaysian cancer landscape, I understand that standard first-line treatments are available, widely available. But the issue is often, the innovative therapeutics, the more expensive cutting-edge ones, they may have been already approved by the authorities in Malaysia, but the costs are often too high for patients. What is the government doing to help with patient access programs? Are you working together with NGOs? Are you having early access patient programs that patients can be part of to narrow this gap?
Yeah, yes, of course, we were talking about the cost, and definitely the cost for the treatment is very expensive. And I have a data here based on our direct healthcare costs and indirect costs of NCDs and the risk factors in Malaysia. This study has been conducted in 2017, and this study has been presented to us in somewhere in 2020. And the total direct and indirect costs, because we were talking about the direct cost just now, the direct costs total with the direct and indirect costs was approximately around ringgit Malaysia 22.53 billion, and it's actually roughly around 2% of the Malaysian GDP. And cancer, the direct cost of the cancer actually around 14% compared to diabetes and cardiovascular. So this is something that we should be looking into when we were talking about the economic burden of the cancer. But definitely, we also need to look into the indirect costs like absenteeism, presenteeism, where they need to be admitted in the hospital and so on and so forth. But in order to overcome the barrier, definitely the Ministry of Health is actually strengthening our care program, especially in terms of cancer. As you noted that I'm looking overall into the non-communicable disease program, and cancer is one of the program in the non-communicable disease under this disease control division. So what we have right now, we started from the primary prevention, secondary, tertiary as well, which include the treatment and the palliative care and to all the spectrum from primary, secondary, and tertiary prevention. And of course, screening is one of the thing that we offered. But we only at the moment we have breast cancer, mammogram, clinical breast examination. We have colorectal screening, IFOP test, cervical cancer, HPV, also oral cancer. But in a near future, we are also looking forward to work together with many NGOs, many agencies to embark into a new way of how we can go on into the screening of lung cancer. As you noted just now, I've already mentioned that lung cancer is one of the most prevalent one in Malaysia. So this is another thing. And then we are also looking into the liver cancer and how we can actually screen. We have been doing a lot of vaccinations before, to prevent the liver cancer, but we are also looking into the rise in the numbers of diabetic patients, obesity in Malaysia, so which is actually related to all this cancer. So screening is one thing, and definitely not only screening, the very most important thing after you screen, you must diagnose the patient if we found something. So this is another barrier that we have right now, where sometimes when you screen people, you need to do confirmatory tests. So this is another thing that we are going forward to have strengthen our control, working together with we are closely working together with National Cancer Society, and of course recently in our World Cancer Day, filling up the gap. So we have discussion with I think more than 30 NGOs, and at the moment in our next national strategic plan for non-communicable diseases, we are going to put in the cancer program to put in a one umbrella of all the NGOs who's actually working together all this while looking into the cancer program so that we can close the barrier. At the moment, what we have hospitals for the oncology. We have 7 Ministry of Health hospitals and 3 universities. We have oncologists, and then we have also pediatric hematology oncology services as well in around 10 hospitals. But definitely it's not enough based on the data that I presented just now. Yes, we are looking forward to work together with all the 30 NGOs and private hospitals, private GPs in terms of screening, and also all the agencies that we can to overcome the barriers. And we are going to have a technical working group based on, as I mentioned just now, the spectrum from primary, secondary, tertiary, and so on. So these are ongoing, and I really hope that all these plans will be implemented hopefully by next year, because this year we are going to strengthening everything, discuss and all that, so that next year we can embark into all these barrier that we were talking about, so that we can diagnose them early, we can screen, diagnose and give a proper treatment in terms of the cancer, as been mentioned by Ms. Shah just now, that they have a too shock already, shock about the diagnosing of cancer, and then of course the cost of the certain treatment that is not available in government hospital, they need to be referred to someone else. And then in the Sabah and Sarawak, for example, in fact in the Kelantan, Terengganu, sometimes they need to be referred to to the university hospitals and all that. So yeah, we are working very close on doing that.
So, Dr. Norariana, what I'm hearing is that it takes a village to close the healthcare access gaps in Malaysia. So, the main focus of the conversation has been mostly on costs. So, I'd like to direct this question to Dr. Tan about other gaps in access. So, you're looking at patients falling through the cracks in the healthcare system from the point of from when they first get diagnosed or from their first visit to a physician, right through to when they first get their treatment. So what are the gaps that they might experience that are not necessarily associated with costs?
I think generally number one is that, like what Dr. Murali did mention earlier, the systemic problem, which means that it's access to healthcare facilities. So I think being in the west of Malaysia, we are fortunate that we can easily access to healthcare facilities, both being public as well as private. Right? Probably you can just take a train and then probably within half an hour you can reach a hospital and walk into the healthcare screening to get whatever test that you need to do. But just to share an example, I think in east of Malaysia, one of the states, Sarawak State. So at one time, actually I had a patient, right, coming into my clinic in the afternoon at 2 p.m. So, when the patient first came in, and then I just asked them, how are you today? And so, what time you left your house yesterday? So I was probably expecting, probably like an hour or two ago or so, or probably earlier when the patient dropped by for some lunch before they come into the clinic, right? But patient answered me at 7 a.m., right? And then when I asked 7 a.m., he said, yeah, yesterday 7 a.m. So actually patients took them more than 24 hours, right, for them to actually reach healthcare facilities with cancer services or oncology services. Mm-hmm. So when we try to ask further, generally because of the geographical region of Sarawak State being huge, just like Peninsular Malaysia, so there are some patients who are really staying in the rural area where they actually have to walk for a couple of hours before they reach their nearest transport, which is probably can be just a usual sampan, for them to get into a larger river, and then finally take a 12-hour bus for them to reach the bigger city and etc. before they actually finally manage to come to a hospital. So for this patient, of course, I can understand that, when they do have some symptoms or they do have something, example, a lump in the breast, but because it's not causing much problem, it's very difficult for them to actually just go to the neural hospital to get themselves checked and diagnosed. Hence, I think that's one of the gap in terms of access to healthcare, right? Of course, I think the other one is that in terms of even if you reach healthcare facilities, not all healthcare facilities have equal services being available. Like what Dr. Arena did mention earlier, only 7 Ministry of Health hospital has oncology services, right? Likewise, I think it's the same with other specialty as well at the same time. So when the patient comes in, right, with certain symptoms or certain complaint, sometimes the hospital might not have the specialty or the facilities for them to actually to diagnose the patient. And the patient need to be referred to another centers, tertiary centers, for them to undergo all this investigation and processes before they come to a diagnosis finally. And like we're all aware, I think public healthcare is really crowded with a lot of patients. So I think in the process of referring to another centers, tertiary centers, because of the waiting time and all these things, so patients tend to sometimes lost to follow up, or things got worse where the patient actually are not able to, go to the hospital for whatever reason and things like that. And hence there's a delay in terms of diagnosis as well at the same time. So there are a lot of challenges, besides just cost alone being one of the major ones. There are also other challenges that making why the patients are presenting late at diagnosis.
So for a healthcare access company, how do you bring together the multiple stakeholders to assess the situation in terms of what gaps there are for patients?
So first of all, throughout engaging with each stakeholder, of course, separately as per their part. Let's just start with the HCP, which is usually the main source of referral. We do engage with the HCPs to introduce the programs for them, ensure that they are the true source of referral to refer the medically eligible patient. Then, throughout following up with patient and ensuring taking them into the process to help them to see how we could cover their treatment. First of all, we collaborate with the NGOs and charities to see the suitability of them being able to help the patient in covering them in some of the part of the treatment as per, of course, the charity laws and regulations. Also, we check with the insurance in case the patient has insurance to see what coverage do they have, how we could really use this coverage also part for the treatment. And we coordinate with the pharmaceutical companies to see how they could offer more support for the patient to ensure a sustainable, a smooth journey for them. Of course, all of this is being under the umbrella and the endorsement of the MOH with their approvals or being aware about the program and to ensure the compliant and sustainable program. Of course, we engage with other stakeholders like the distributors and the pharmacies to ensure the logistics and the accurate logistics are being there to ensure the smooth journey of the patient from the day of referral till the treatment collection and continuation on their treatment.
Yes, so we are talking about, again, bringing the village together. It takes a village for cancer patients to be able to be diagnosed right through to treatment and get better. So before we can even get through to the entire process of, getting the funds and means to give the cancer patients the treatments that they need, they first need to be diagnosed. And I think diagnosis in Malaysia is a concern. So I'm going to be directing this question to Dr. Murali with regards to the downstaging initiatives that NCSM has been spearheading the last few years. Why is it so important to get patients diagnosed, and why is it so important to do it early?
Okay, in a really honest sense, the important thing, two things actually. One is money, and the second is life. So to the system, to the healthcare system, there's this huge saving that you get from diagnosing a person early. And Dr. Tan I think, alluded to this earlier as well. So when you pick up someone in like stage 1, stage 2, it doesn't cost nearly as much to treat them. And more importantly, these people go on back to living, very normal, good lives, and that's the big difference. So in stage 3 and 4, you diagnose them, and now thanks to a lot of like modern therapeutics, you can treat them, you can manage them. In some cases, there's even people coming out with cures, but it's just ridiculously much more. It just costs so much more to get these people up and about again. So for us, from a country perspective, from a community perspective, it makes sense because in Malaysia, as you were saying, almost 60% of all our cancers are diagnosed in stages 3 or 4. In some cancers, like lung cancer, it's miserable. It's like close to like 90%, or slightly more than 90% is actually diagnosed in 3 or 4. So how do we turn back the needle? We just need to diagnose them early. And coming back to what everyone's saying, including yourself, it needs everybody's kind of role to make this happen. So for example, Dr. and Dr. Ariana, Dr. Tan, they were saying one of the challenges is we don't have hospitals everywhere. But no government in any country is going to build hospitals anywhere. So where do people like NGOs come in and the Ministry of Health comes in, or even people like Dr. Tan come in, is sometimes they reach across to us. They tell us that, hey, I've got a patient who needs to travel like 2 days to come and see me. Can you like arrange for lodging? So one of the things that we do is we put up transit homes all over the country wherever there's a government hospital that treats oncology. And usually, like thankfully, it's usually near to the private hospitals as well. So when there's patients who are less needy, who are less able to kind of manage these costs, they need to travel from afar. These are things that we can put up to defray their costs. So, for example, we worked with labs, I think in 2021, 2022. So we got all the labs in Malaysia to kind of come to a consensus to actually reduce the price of molecular diagnostics for cancer by more than 30%. So this is a saving not only to the private patients, but also to the government, because the government sends to all these labs as well. So it's all these little things that we work together in so many different ways that actually manage to move the patient, like reduce the cost and get to an earlier diagnosis. And hopefully we're trying, I think all of us work to kind of move the needle a little bit back. But the reality is 60% of our patients are still in 3 or 4. And then that's when we come to the other part of the picture, which is we need to manage them, we need to treat them.
So we are now familiar with, if you've listened to all the panelists, you're now familiar with the role of the government and the extent of their reach in helping with early diagnosis and implementing certain programs, for example. You know, the role of the healthcare practitioner, the oncologist, the medical oncologist in treating the patients, the role of NGOs to help look at what other missing keys that could help further narrow the gaps. But having a healthcare access company is a completely different beast altogether. Not many people know what is their role. And earlier on, Ms. Shahad has spoken a little bit about how they work with multiple stakeholders like pharmaceutical companies who create these drugs, who invent cures and medicines for cancer, for example, and approaching different parties like the NGOs and non-government organizations, the Ministry of Health and the HCPs, you know, whether they are private practitioners or with the public service. So maybe, Ms. Shahad, can you explain a little bit about the value that you bring to the cancer patient's journey as a healthcare access company?
In the beginning, if we go historically a bit how it was started, let's say the basic offered solution. The basic offered solution was relying on, let's say, in a simple way, they were calling it a fixed scheme. It means that the patient has to purchase throughout the treatment plan or throughout 1 year certain number of packs, and accordingly to get another number of packs, for example, as a free of charge. For example, you have to buy 1 box to be able to get the second box as a free of charge, despite what is your affordability. Where here, Axios came because we believe that there is one size doesn't fit all, and we need to ensure to maximize the patient benefit. And from patient-centric approach, we came with the model of the cost-sharing model based on the patient affordability. This tool, it truly measures what the patient affordability and how much really they could afford throughout the 1-year treatment plan. Using this solution, it helped us to really know, first of all, the patient affordability, then to collaborate with the other stakeholders like the insurance company to fund some of the patient, of course, based on their coverage. Also have the support, of course, of the local charities and NGOs, and especially NCSM, to be there also to support the patient and to help them to create with them a treatment plan that is sustainable. And with time and over the years, we are still evolving our solutions to ensure we are addressing all the arms and to ensure that smooth and easy journey to reach to a way that to the right patient, reach the right treatment in the right time and using the right way.
Right. You talk about an assessment tool. You know, you assess the patients based on whether they can afford certain treatments and how much or well they can pay for treatment with the collaboration of all the different stakeholders. So what are some of the markers that you use to assess patients?
Great. So this tool, it stands on three main elements. It starts on the income, assets, and the standards of living. Usually, I'll mention a very simple example. We say it. If you have one patient who is having a salary of 30 ringgit and is single, living alone, is totally different than a patient who is also earning a 30 ringgit, but he has a family, children to take care of, university school fees. All of this is a burden. So our tool, it's touching all these bases to really know how much exactly the patient could afford throughout the treatment plan. Of course, this tool is patent and validated and also has been tested on patients where it shows a very high percentage of accuracy. And also we are using it with our patient to really know how much you could afford and accordingly how much you could pay over the month, over 1 year of treatment plan.
That sounds really interesting. It's something that many patients might not have heard about. So maybe we can ask Dr. Tan with regards to putting patients on healthcare access programs. How is it different from the other modes of payment? What kind of benefit that patients can experience from this?
I think traditionally it's just like when you go to a shop to buy goods, right? So you want to buy one box, you pay for it. If you want to buy 2 boxes, then you pay for 2 boxes, right? But I think with access program, what it does really helps is that I think it able to give patients some breather in the sense that they don't have to pay every single month out of their pocket. So they probably need to pay, like say this month, and then next month they don't have to pay, but they can still continue to have access to the same drugs into their treatments. So in a way, they have a breather, right? So there are some programs where they even have a cap, meaning that once the patient has been on this treatment for a number of durations, then subsequently, as long as patients still benefit and require the drugs, then they get it for free. So that is a cap. So some of the companies like Axios, what they're offering is more like a mean base. So like you earlier on when I think you did mention is that because of the cost for you to come up with innovative products, right? Someone have to pay for it, right? If not the patients, then you have to be from the companies or you have to be from the governments and all. So it will not be free, right? So what it does here is that mean base, meaning that they will then assess the patient's financial situations. So for those who they think that example, they can only afford to buy, say, 3 out of 12 months, right? So they will buy the 3 months and then they get the 9 months free. So that patient will have continued access to the treatment for the 1 whole year. But for those who are a bit financially better off, then they probably need to buy 6 months before they get the other 6 months free. So it helps to balance out, to make it more sustainable for everyone in general. But of course, if you look at individual level, therefore those who need to buy 6 for them to get 6 free, they felt it's a bit unfair as opposed to someone who needs to only buy 3 but they get 9 months free, right? But that is in a way try to make it more sustainable and cover up, like I mentioned, the cost of the innovative product being so high. Somehow you just will not be able to offer it equal, for everyone.
Right, and the gaps in healthcare access to cancer treatments is not just about cost. I mean, you talked about a little bit about how patients from rural areas will have to take long leaves and spend a long time traveling to the city center where the drugs are administered. So let us know a little bit about your experience about the importance of building communities around patients with cancer or cancer survivors, for example, to help support them through this journey. What do you think of that, Dr. Murali?
So you're absolutely right now. It's absolutely critical because a lot of costs are hidden costs. So I think we talk about treatment a little bit, and one of the things that patients are always most concerned about is the cost of the drugs. But very often, for example, there's this huge amount of mental kind of anxiety. Almost 2/3 of cancer patients, for example, have a serious mental health issue which kind of exists alongside. And again, access to mental health professionals is something that's not always easily available, one, and second, it's not cheap. So again, here's where people can come in to assist. For example, we and a couple of other organizations, we actually offer mental health support to patients like within the government system. We actually have staff, clinical psychologists, counselors who sit within government hospitals, filling up that gap to help overcome the waiting for government patients. Because, for example, some hospitals have one psychologist and they have to serve like the entire hospital. So we put in protected headcounts. Like, for example, there's a clinical psychologist who runs, our clinical psychologist who runs a clinic in Hospital Kuala Lumpur and now IKN as well. So that helps to offload the kind of burden. People get to see and get the help that they need very quickly. Most importantly, it's accessible. And when it's paired in support of things like, for example, Dr. Tan starts someone on a drug, and the drug is clinically very useful. And thank God to, for example, access programs, patient may be a little bit relieved in terms of pain. But there's all these kind of dietary issues, mental health issues, and when we bundle these programs together, so for example, patient coming onto these programs, we also bundle like psychosocial support, and people like the referring healthcare professional, the physicians, people like Axios who run these programs, they kind of bundle these things together to make it available to the patient, and together this helps make the journey a little smoother for that patient and the family as well.
So we talk about other gaps with regards to keeping the patient on treatment. That's also a challenge, especially if you live in the rural areas. So this is a question for Ms. Shahad. I understand that Axios International has got means for following up with patients outside of the hospital setting. And this is really essential, especially for patients who can't afford to stay in, say, Kuala Lumpur for the next 12 months to undergo cancer treatment. So what tools does Axios International have in place to help these patients to ensure that they continue on treatment?
Echoing, of course, what Dr. Murray was saying, and this is what we came also to see from the years of experience and implementation. The challenge of the patient went even beyond affordability. It's about being aware about their disease, about having the proper follow-up and being cared of, whether it was the patient or the caregiver, from mental status, from education point of view. So we have a services also was there for the patient, which is, we call it access to adherence, or ensuring that the patient also adhering to the treatment, to increase the patient compliance on the treatment, improve the duration and treatment, and to reduce the amount of the patient dropping out from their treatment due to the other challenges other than the affordability. So we are there always for the patients, like we are offering them the education sessions for the patient and the caregiver. We are also offering them the remote care for the patients, and especially those who are in rural area, like the medication delivery, medication administrations, having there to also collaborate with the, for example, NCSMs, also other aspects, starting from education to other services. Even, for example, sometimes we offer transportation for the patients, that the patient are not being able to go to visit their physician because they don't have even the cost of, for example, a transportation to go to their physicians. So we are also helping with the support, of course, with the, as a program to help in covering this patient with such kind of services, to give them the all the tools to ensure that they're being compliant and adhering to their treatment.
Right, and so for the final part of the webinar, we'd like to talk about more about the multi-stakeholder collaboration. So everyone is used to each other in the system. The pharma companies know of healthcare access programs. The healthcare access programs are aware of HCPs, the healthcare professionals. But what else can be done to close the gap even further? So this is a question I'm directing to Dr. Noor Ariana with regards to public-private partnerships. And this is often a very interesting topic and sensitive issue. When I talk about private partnerships, public-private partnerships, I'm referring to collaborations with industry, and I mean pharmaceutical companies with regards to maybe clinical trials, organizing early patient access programs. Are there any steps that the Malaysian government is doing to close that gap, at least with the industry?
Yeah, thank you so much for that question. And I think this is a very crucial and very important point that we need to talk about and discuss in terms of the multi-sectoral collaboration. I think in this world we cannot work alone. There's no one can be very achieve any success story if we work in silo. In fact, in the Ministry of Health, in our Ministry of Health, we have many divisions. We are also we need to be collaborating from one division to another division, because I'm working in the public health divisions, and of course Dr. Tan in the clinical division, and also Dr. Murali in NGOs and all that. So we must be working together as a team. Working on the multi-sectoral collaboration is very, very important. By talking about public-private partnership in the disease control division, we have been practicing this public-private partnership even 10 years ago when I was in the one of the sector here, one of the main important contribution of risk factors to cancer, tobacco. We have been embarking into this public-private partnership under the program of quit smoking before. So we have been doing all these public-private partnership, working together with the NGOs, the private companies, even the pharmaceutical companies. But we have to put it in terms of a very good collaboration under document. It has to be documented. It is under the memorandum of agreement or memorandum of understanding, so that we know each of our partners in the collaboration, they know their own roles. So this had happened in the disease control division itself under the non-communicable diseases. But what I would like to draw your attention right now is how the Ministry of Health is actually closing the gaps in terms of this public-private partnership is by having our health white paper. I think you have heard about passing the health white paper in the parliament last year. And one of the main core things in terms of this health white paper is on the public-private partnership. So that's why myself and my team right now, we have quite a good team in this cancer program. We are looking forward to have this public-private partnership. As I mentioned just now, we are going to have this technical working group, and this technical working group must be documented in a good memorandum of collaboration, and we have to outline our own role. In fact, I know whether you need to closing the gap in terms of prevention, doing a lot of education, whether it's actually closing the gap in terms of the screening, and then and how we have to diagnose the new treatment, new modality, and definitely National Cancer Society, for example, they are helping us a lot in terms of the palliative care, the mental health issues of these patients. So the point here is, yes, we are actually trying to close the gap in terms of this public-private partnership, but of course, as a government policy, we need to be make it very clear. It has to be documented, and we have to know our own role, so that we don't duplicate the work and the role. Yeah.
Okay, this is a question for Dr. Murali. It seems that you're a very busy person plugging a lot of gaps and leaks, like a plumber, So I would like to ask you, obviously the best way to deal with the problem is at the root, and, that can cover to some extent policy changes. So to what extent and how much has NCSM contributed to the formation of some policies with regards to cancer treatment?
Oh, absolutely. So I think two big pieces of work is actually, as Dr. Ariana was saying, I think we've been one of the important and long-time movers of the National Tobacco Control Act, which took almost about 20 years to actually come to fruition and get passed. So that's a big piece of legislation that we actually moved, which was just came into force, I think, in February, and then it's coming into actually enforcement now. So that's a big piece of legislation. We also, I think, a lot of, I think Dr. Ariana was mentioning this slightly as well. This year, I think there's a very active kind of amalgamation of private, public, civil society kind of coming together to actually put very concrete plans and roles and responsibilities for, in terms of the National Cancer Control Plan that's being rolled out. I think for 2025, we'll actually have a new set of plans which run for about 5 years. And in that, for the first time, I think civil society is being given very concrete KPIs, indicators, targets. And the idea is for us to be able to work alongside the ministry as well as with our clinicians across the country in order to close a little bit more of these gaps. The beautiful thing is about gaps is I think we need to continue looking for gaps throughout. And there'll always be gaps, and this is the quality that we need to kind of adhere to. Look continuously to see how we can further improve. And by doing so, we help the patients.
And this is a question for Mr. Hart. So how do you perceive Axios and the other stakeholders, given the resources that you have implemented in your access programs, given the resources in terms of NGO support, government support, how do you see yourself further close these gaps? Are there any projects in the pipeline that you'd like to share with us?
We are working with them to make our solutions more innovative and to increase more accessibility and maximize the patient benefit. So now, and we have already announced it in more than one conference, the publishing or introduction of the concept of the on-time access solution in Malaysia after implementing it in several countries. So what is this concept about? It's about reducing also more the timeline from referral till starting on treatment for the patients who really cannot afford their treatment by offering them an international fund has been run through a fundraising activity that Axios has been running with international charities and NGOs to allocate these funds for the patient, where this patient, it will be helping them to start on their treatment ASAP, of course, with the collaboration and the assistance of the local charities and NGOs and the endorsement, of course, of the regulator to help the patient to start ASAP on their treatment. And also the patient will be able to really pay based on what they can afford, and the rest will be covered by the under this concept of the on-time access, where this will be a true transfer for it, as we are also starting the patient on treatment, working with the local charities and NGOs to follow their processes and take their time to approve the patient and also help further. And in the same time, but the patient is on treatment, there is no interruption, and we are following the HCP's, of course, recommendation to start the patient ASAP and not to interrupt the clinical impact in it. Also, we're looking for more than one solutions, like to cover in case of a patient who have an insurance, but still they have a monthly co-payment, we could cover for them. Also introducing the digitalization in place to reduce the amount of the paperwork, whether it was on the patient side or on the physician side, to make it more accessible also to the program, to make also the patient is easy to communicate, and also the physician is easier for them to reach out to the program, whether it was to refer, to follow up with the patient status, and being able to reach more for the patient. So in simple, all our projects are being focusing on making the patient journey smoother, also looking, of course, to expand the projects with more pharmaceutical companies to help more patients and maximize the patient benefit.
All right, before we end, I'd like to talk a little bit about the misinformation that patients often get themselves embroiled in. There are non-evidence-based sources like Dr. Google, Professor TikTok. What is the importance of PAGs or patient advocacy groups in ensuring patients get the right information about evidence-based treatments? And this is a question I'd like to address give to Dr. Tan to answer.
Yep. So I think once the patient is being diagnosed, especially with cancer, right, it's unlike the other usual non-cancer diagnosis, where the patient actually like to seek for more opinions. So they normally tends to go for doctor shoppings, and then they, like you mentioned earlier, they will refer to Dr. Google, Professor TikTok for all these informations, right? But ultimately, another thing is good about in Malaysia is that we have very good and strong patient advocacy group, patient support group like NCSM, for example, where through their members, they are able to reach out to a lot of these patients, both those survivors as well as those newly diagnosed at the same time. I think via these societies, this PAG, right, we are able to reach out to more of these patients, and through them, I think it is a good channel for us to actually provide them with the right informations, the correct informations. And via these societies as well at the same time, that's where we actually are able to go, example, to give a talks, share informations, participate in their activities, where we are able to actually has a chance to connect with the patients or more patients, in fact, to share the actual and the authentic or the real informations rather than them going through the internet or Google to look for the answers.
Okay, we've come to the end of the webinar. And again, I'd like to underline that it takes a village for cancer patients to get their treatments in the best way possible. Many factors play into this, closing the gaps in healthcare access. Many people play a part. As I mentioned, we have a whole panel here. I'd like to thank all our panelists. Dr. Noor Ariana, thank you, Ms. Shahad. I'd like to thank Dr. Tan and Dr. Murali for joining me on this panel. But before we end, I'd like to ask each and every one of the panelists, what would be your wish for cancer patients? If you have a genie that turned out from a bottle, you rub the bottle, right? And the genie pops up, and you're given one wish for cancer patients, what would that be? And I'll start with Dr. Noor Ariana.
Yes, of course, my wish is do your screening and know your status, and please get yourself get your proper treatment. So that's my wish, and I hope that we can work together with a good collaboration with everyone.
Ms. Shahad, how about you?
Of course, as always, Axios is always aiming that the right patients get the right treatment in the right time and the right way. And we will always work to give an innovative solutions to make the patient journey smooth and easy, and to be always there with the patients.
Okay, Dr. Murali, you're next.
So, I wish for a world in which everyone can get diagnosed early, get treated early, and most importantly, get back onto living fulfilling, good lives.
And Dr. Tan, because you're the closest to the patient.
Of course, if let's say I have a genie, I think I will wish for there's no cancer. Right? So no one will suffer. But I'll probably be loss of jobless. So just joking. So I think just to echo what the others have said, right? I think do not know how we're going to do it. Probably the whole village have to work together. If we can get more patients coming in, right, the next day to say that okay, I have reached certain age. Hence I actually need to go and do screening for certain cancers and all. And hence we are able to move the needle and being more patients being diagnosed earlier. Then I think that is actually very important, because I think besides talking about the direct cost of treatment being higher if let's say it's diagnosed in later stage as well, I think it's also important in the sense that when the patients are cured, right, they're able to come back to the society, to work, live their normal life. And in return, they're actually also contributing to the countries at the same time. So I think in general, I think besides just the patient itself, it's also good for the societies as well as for the country, for patients to come in and diagnose earlier and get the appropriate treatment.
I'd like to thank everyone for joining me on this webinar, including the panelists. The journey for every cancer patient is different. It can get very confusing. There are very many different resources and sources of information. So these are the panelists. Please Google them, look them up, and see the best way for you to move forward. And thank you very much to the panelists for joining me. We hope to see you really soon. Thank you.
Axios, transforming access to healthcare.